Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and I'm joined today by Dr. Christina Enzmann, a gynecologist and menopause specialist with MedStar Good Samaritan Hospital, and Dr. Brian Swehla, an interventional radiologist with MedStar Health. We are a proud partner with Red Hot Mamas, the leading nonprofit provider of menopause education and support programs in the US and Canada. Today, we're going to talk about the relationship between perimenopause and uterine fibroids. Our experts will define the stages and symptoms of menopause, as well as define uterine fibroids. You'll walk away today with some tips to manage menopause with traditional and alternative treatment options, and you'll learn about the options for managing uterine fibroids. So if you or someone you know is suffering through the stages of menopause and has pain that can be fibroids, you're in the right place to gain information and learn how you can improve your health. Please share this broadcast with your friends and family. Give us a like, let us know that you're watching, and if you have any questions, ask them in the comments. Let's meet today's guests. Dr. Christina Enzmann is a board-certified gynecologist with experience in menopausal medicine, endometriosis, fibroid management, and minimally invasive surgery. She went to medical school and completed her residency at the University Hamburg in Germany, as well as an additional residency at Sinai Hospital in Baltimore. She wants to empower women to conquer their menopausal transitions as a positive health milestone and help them enjoy their midlife to the fullest. Welcome, Dr. Enzmann.
Hello.
And Dr. Brian Swehla is a board-certified vascular interventional radiologist. He completed medical school at Temple University School of Dentistry, his residency at Penn State Milton S. Hershey Medical Center, and his fellowship at the University of Maryland Medical Center. He specializes in minimally invasive image-guided procedures using CT scan, X-ray, and ultrasound. His interests include uterine fibroid embolization and minimally invasive cancer therapy. He has been named a top doctor in Baltimore Magazine for interventional radiology for the last 8 years. Wow. Welcome, Dr. Brian Swehla. Appreciate you being here.
Thank you.
All right, well, let's get started. I have a lot of questions for you. Let's start with the basics. Dr. Enzmann, I'm going to start with you. We often hear the terms perimenopause, menopause, and postmenopause. Can you talk about the differences between the three just to get everyone reacclimated to this? I know we've talked about it in other Facebook Lives, but can you go into that for us today?
Yes, you're just going to get them warmed up because I'm really excited to talk today to my friend Brian Swehla, who obviously work a lot together, and so I'm really happy to have him here today. So the perimenopause is really the time when the hormonals are going on that roller coaster, can take for several years. And this is basically the time leading up to the last menstrual period, plus the first year that comes after the last menstrual period. That is all perimenopause. Menopause, that term is correctly really only that last menstrual period. So you could say your menopause was in April 2018. That is really that one time. Even we use it for the entire time that comes afterwards in colloquial way. However, correctly, that's actually postmenopause. So everyone that has seen their last menstrual period is actually a postmenopausal woman. That's that.
All right. Thank you so much. Appreciate that. Can you talk about those symptoms, just to remind everyone, what are the symptoms of menopause? And can you talk about the treatment options available?
Yes. So basically, what brings on menopause is that ovarian aging. The ovaries basically stop producing their large amount of female hormones. We can still produce them in small amounts in other organs, but that big roller coaster up and down every month is basically stops slowly in postmenopause. And since pretty much most of our organs have some type of estrogen receptor, that is the cause that the symptoms can be so can be so multiple, can be so confusing, and can be very different in every woman. But the most common ones that everyone has heard about are the hot flashes, like the sensation of intense heat on your head or your upper body. Sometimes it disrupts the sleep, then we call them night sweats. In the end, it's the same thing. Many women get them, not all of them. Just be aware. It's not like everyone really has to have them, but that's the typical thing. What often comes also with this hormonal fluctuation and the decrease of estrogen are sleep disturbances. So you can't either fall asleep or you can't stay asleep, or you wake up in the middle of the night and you're wide awake. Some women complain about joint pains, changes in hair and nail. There can be GI issues, not so well known. So having suddenly gastrointestinal problems, and you think you have something like IBS, but it can just be a change of the estrobolome. So basically the estrogen-dependent bacteria in your gut. And some women get palpitations. Also has to do just with the estrogen receptors. So these are the most common ones.
All right, thank you so much. And what about treatment options? Can you talk about HRT and the safety of that, and any other alternative and functional medicine that is used to treat menopause?
Yes. So first of all, menopause is not a disease or postmenopause. It's something that nature invented for us, and we kind of go through it, and we can have a vibrant, lovely life afterwards. It's just that transitioning for our post-reproductive years. So hormone replacement therapy, because everyone always wants to know that, is very effective for the hot flashes. Actually, it's FDA approved for that. It works very well and very fast. It with that can also help with sleeping, just because you're not getting disturbed by your night sweats. The other FDA approved indications are a prevention of osteoporosis. So if there's a strong family history of fragile bones, this might be something to consider. And it's also preventing the atrophy of the genital tissue. So it helps with urinary frequency or urgency, and pain with intercourse, which is usually something that comes in later postmenopause. So it helps very well for all of these. And for young menopausal women, so meaning the ones that are just entering menopause around age 50, and if they are younger than age 60. So we know for these women, the benefit outweighs the risks. That doesn't mean you have to start this or this is something for everyone. But if you are having severe symptoms, that is an option. And there are a couple of strict contraindications, which would be if you had yourself breast cancer, or yourself have uncontrolled hypertension, or you had a pulmonary embolism or deep vein thrombosis. So these women cannot take it at all. So that is the hormone replacement therapy. But again, don't feel pressured. It's not, because it always goes from don't take the hormones, and then after 15 years, it's like everyone takes hormones again. It's not like that. So it's up to you, and it depends on your symptoms, and discuss that with your physician if you want to try that. Lifestyle changes can be highly effective, and there are very good studies, and they basically target to balance your hormones, which would be, I always say, quit sugar. So we are targeting inflammation. So quit eating sugar, be very careful with caffeine, and eat lots of greens and veggies, because we know now they're actually turning on the good genes that we need, the anti-inflammatory genes and the anti-cancer genes. So make sure, I always say, eat 80% plant-based, okay? And then everything else might not be so wild, okay? Very important. And yes, the sugar. So this is, and there are, of course, some herbal stuff, but we're not going to go into this today, because today we wanted to talk about the fibroids.
All right, that's a great transition. Thank you, Dr. Enzmann, and thank you for getting everybody warmed up. So yeah, speaking of fibroids, that's what we're going to talk about next. So Dr. Swehla, what is a fibroid? How are they caused?
Sure. So fibroids are benign, non-cancerous tumors that will develop in the uterine wall. The uterus is primarily made up of muscle tissue, and there can be mutations that occur in the muscle tissue. It basically cause these fibroids to form. Again, these are non-cancerous, benign tumors. Why they form is still a little bit a mystery. We know there are certain groups of women that are a little more prone to develop fibroids. That includes African American women, women that started menstruating at a very young age, women that have never been pregnant before. So fibroids, again, are benign tumors that grow in the uterine wall and can be quite quite disruptive in terms of the symptoms that they cause.
Thank you so much. How are they caused?
So we know that there are factors that play into the growth of fibroids, estrogen, progesterone. Why in some women they are formed or why they develop as opposed to other women is still not exactly clear. There are definitely correlations with family history. So if mom and aunts and sisters have had fibroids, we know women may be more at risk. There's been also links with eating excessive red meat. And like I mentioned before, there's certain groups of women, Black women, for instance, again, that are at, we don't know exactly why, but at increased risk or have a higher chance of developing fibroids.
Okay, thank you so much. You mentioned symptoms earlier. Can you talk about what symptoms someone would experience and how, if someone feels like they could have fibroids, how would they be diagnosed with it?
Yeah, that's a great question. The symptoms are there's several that most women that are having difficult or having fibroids or causing these things experience. Heavy bleeding during their periods is probably the number one thing that we see fibroids cause. So we use the term menorrhagia. That's the medical term for just excessive heavy periods. So we'll have women referred or coming to see us, seeing Dr. Enzmann, who they are changing pads and tampons sometimes every 30 minutes on their during their cycle on their heaviest days. These are women that have very low blood counts because of the excessive bleeding. Some have had to be on oral iron pills, IV iron infusions. Some have had to have blood transfusions in the past. So the heavy bleeding is probably the most significant symptom that we see. It can be one of the more debilitating symptoms, and then pain, crampy pain, either right before or especially during a woman's period. That can also be very debilitating. And we'll have women that are, taking Motrin, taking Tylenol to try and help, kind of keep the pain under control. Some women are dealing with such excessive, again, bleeding and pain, they're having to call out of work during that time of the month where they're menstruating. So those are two of the biggest symptoms. Then we have symptoms of bloating and sort of this heaviness that's experienced in the belly. This could just be feeling full all the time, not having much of an appetite. This can vary throughout the month, but can be really really noticeable right before a woman's period starts. And then pressure on the bladder is another, and leading to urinary frequency, running to the bathroom often during the day, waking up several times at night to urinate, and that is due to the size of the uterus enlarged by the fibroids pushing down on the bladder. So heavy bleeding, really severe menstrual cramps, and then like the bloating and then the pressure on the bladder and the urinary frequency are some of the most common symptoms that women complain of. Now, those symptoms could also be related to other things that aren't fibroids, but if those symptoms are present, some of the diagnostic sort of tools that are used, one would be an examination with the gynecologist in the clinic. And then if there's a suspicion for fibroids based on the exam, and then the symptoms, an ultrasound is usually done. And it's a very, very sensitive way of identifying whether fibroids are present.
Okay, thank you very much. Yeah, those symptoms definitely sound debilitating. You mentioned in some cases having to change pads and tampons every 30 minutes. I can't even imagine that. That sounds terrible. So the fact that we can have conversations with our gynecologists, medical providers, and look to see if they are being caused by fibroids or maybe something else. Sounds really reassuring. Can you talk about how fibroids relate to perimenopause? Dr. Enzmann was reminding us what perimenopause is earlier in the discussion, but how do fibroids relate to that part of a woman's journey?
Sure. So a lot of the women that we see, that Dr. Enzmann sees and refers to me, are approaching menopause. So some of them may have gotten to the point where they're starting to miss periods, but the periods that they still are having due to fibroids are very, very heavy. And again, she mentioned kind of the roller coaster that's occurring with the hormones and things like that, and that can be, at play with a woman that has fibroids present. So what we see are women that often are experiencing, again, these very debilitating periods. They are close to menopause, maybe within a few years. They may be in their mid 40s, late 40s, early 50s. We talk about the average age of menopause is 51. So I see a lot of women that are approaching that age, and their fibroids are just, again, really, really problematic for them. They know that they're going to be, their periods are going to be stopping soon. And some of them, like I mentioned, are missing periods. Some periods that they do have are on the lighter side, but then the next month, they'll just have this incredibly heavy period. And so they're looking for options to try and get them as what we kind of call as a kind of a bridge to menopause. And there's surgical options, which Dr. Enzmann, performs everything from one extreme, hysterectomy, to less invasive surgical procedures. And then there are procedures like what I offer, uterine fibroid embolization. And I know we'll talk a little bit more about that. I know there's a few other questions we want to answer before that, and I'll get into the details of uterine fibroid embolization. But the relationship to perimenopause is that often women approaching menopause, their fibroids are active, if you will. They're very just disruptive to their daily life, and they're just hoping they can get to menopause so that all this will start to improve. We know that once menopause occurs, periods stop, and fibroids begin to shrink, but it's getting to that point. And so a lot of women that are perimenopausal are dealing with fibroid symptoms, and they are looking for relief from those.
Yes, and maybe I can just interject here and just add.
Sure.
So to explain this, so in fibroids, really, they thrive on excess estrogen and good blood supply. So, and in perimenopause, you have that excess estrogen. And I didn't really explain this before. We always think, this estrogen kind of trickles away slowly and it gets less and less. That's not the case. From perimenopause, you have this excessive spikes of estrogen. So this is the roller coaster I was saying. It's not like a small roller coaster. It really goes up. And this goes in addition that the progesterone is not balancing that estrogen out anymore, which would help the fibroids. But the progesterone comes from the ovaries when you're ovulating, and that doesn't work well anymore. So these fibroids really, they actually thrive in perimenopause. And then in addition to that, women tend to bleed heavier, sometimes in perimenopause from these hormone disruptions. Now, in addition, we have the underlying fibroids that also like to grow during this time. And that I always say is like the perfect storm. So this is how this all happens and how this ties together.
Thank you so much. And yes, I want to get into more details about treatment for fibroids. But before we do, we talked about symptoms. What about patients who have fibroids but have no symptoms? What happens if a patient is in perimenopause and they have a diagnosis of fibroids, maybe through conversations that they have with their gynecologist, and for whatever reason they need imaging and they have fibroids but they have no symptoms? Can you talk through that as well, and what that process kind of looks like if you don't have symptoms? It felt very clear if you have symptoms it could be fibroids, but can you talk about a patient without any symptoms, Dr. Swehla?
Sure. There's so we know fibroids affect up to 80% of women. which is, when you think about that, a huge number. Ranges maybe from 50 to 80%. So of those women that have fibroids, yes, not all are symptomatic. Not all are struggling with heavy periods. They're not dealing with bloating, cramps, and urinary frequency. So if fibroids have been diagnosed, whether it be on physical exam or and confirmed with an ultrasound, but the patient has absolutely no symptoms. Their periods are very normal and have been very stable over years and years. They have no cramps, very minimal cramps, and they have really no bloating or bladder pressure. For those women, usually we will just kind of watch and wait. And if they are, especially if they're in that mid 40s to early 50s range, we would just counsel them that, eventually their fibroids will just kind of shrink. There's really nothing that we would recommend procedurally, whether it be fibroid embolization or hysterectomy. Just the presence of fibroids without symptoms is not a huge, worry for the patient. We will just reassure them that these fibroids will again shrink down and completely kind of resolve, so to speak. But our approach is not to offer a procedure unless there are symptoms that we can directly draw a connection with the presence of fibroids.
Yeah, and maybe I want to just add. So yes, many of my patients have fibroids, and most of them will not need anything. So we haven't mentioned these fibroids, of course, come in all different sizes. So some patients come like, yeah, I have a fibroid, and I'm going to be like, yeah, it's kind of 3 centimeters, and just one of them, there's nothing you have to do. So just be aware. Only because someone diagnosed you with a fibroid, that doesn't mean you need anything ever. So, there's a small fibroids, and some women have several fibroids that are big like grapefruits. So this is then someone who has, of course, a very different profile of symptoms. So just keep this in mind. And then there are fibroids in different locations. And maybe Dr. Swehla is going to talk about this. So they can kind of poke in the uterine cavity when they tend to cause earlier issues, even when they are smaller, or they're just sitting in the muscular layer, or kind of sometimes they're just hanging off the uterus like a Mickey Mouse ear, we sometimes call it. So all this plays in how symptomatic you might be, actually, if at all.
All right. Thank you so much. Really appreciate all that wonderful information about symptoms and what to look out for, and how you all have conversations with your patients about how to be diagnosed, how to work through the either potential fibroids or the diagnosis of a fibroid. And we'll talk about treatments next. But I did want to just remind our viewers to ask any questions that they have in the comments, and also say thank you for joining us. If you haven't already, give us a like, let us know you're watching. We are joined today by Dr. Christina Enzmann, a gynecologist and menopause specialist with MedStar Good Samaritan Hospital, and Dr. Brian Swehla, an interventional radiologist with MedStar Health. So we've been having a great conversation about fibroids. We are partnered with Red Hot Mamas, the leading nonprofit provider of menopause education and support programs in the United States and Canada, wanting to make sure you have all the information that you need about menopause. And today we're talking about the relationship between perimenopause and uterine fibroids. So we had a lot of great conversation already about what uterine fibroids are, what the symptoms are. And next we're going to talk about treatment. So Dr. Swehla, let's go back to that treatment question that we started talking about earlier. Can you talk through the options to treat fibroids? And Dr. Enzmann, you mentioned this already. When are the times where you have to treat it and when you don't have to treat it? Can you touch on that again for our viewers before we get into more details about the treatment options?
From my perspective, just very brief. So from my perspective, really, if you have no symptoms, or maybe you have some heavier bleeding, but you're really close to menopause, there are other options we have. For heavy bleeding, we can do birth control pills or IUD. So there are many things depending how big these fibroids are. However, once someone really has like debilitating menorrhagia, that maybe we have tried other conservative management options before, let's say birth control pills, IUDs, any of these, and that patient still, for example, shows up in the emergency room regularly and needs blood transfusion, because that really happens frequently, then I'm really saying, let's talk to Dr. Swehla, unless that patient would like a hysterectomy. But, hysterectomy comes with downtime. So I always offer to talk to Dr. Swehla, because many patients are actually excellent candidates for that.
Yeah, thanks,
Thank
Christina. I really think of the treatment options for fibroids as like a spectrum, and Christina's kind of outlined kind of two ends of the spectrum. One would be the medical, I don't want to say simple, but somewhat more simple approach with prescribing birth control. An intrauterine device or IUD might be appropriate. I've seen women that have had very good success on that end of the spectrum with treatment. But if those things aren't working, and the bleeding is just incredibly severe, the cramps and so forth, the other end of the spectrum is surgery, which Dr. Enzmann performs, and that would be hysterectomy. But in this day and age, women have other options and many factors that are going to kind of play into what would work best for them. Again, if the medical management and the simpler things haven't worked, hysterectomy is one option where the uterus is removed surgically. It is a longer recovery time. It can be anywhere from 6 to 8 weeks. And some women just are not in a position to be out of work that long, not being able to help with their family for that long. So options that are less invasive, and I can speak to uterine fibroid embolization or UFE. That's a procedure that's kind of unique in that it's not one that the gynecologist performs. They do the surgical techniques, they'll prescribe the medicines and do the IUD, but the uterine fibroid embolization is done by interventional radiologists, which is my specialty. And we work in blood vessels all the time, whether it be in the uterus or sometimes in the kidneys or liver or intestine. But for the uterus, we use our techniques with minimally invasive little catheters. We're talking about devices that are really just the diameter of a spaghetti noodle, and they're very flexible. They can be inserted through the wrist artery or the groin artery. And under live x-ray, while a patient's under like twilight sedation, we can advance those catheters into the arteries feeding the uterus and feeding the fibroids. Fibroids have a lot of blood vessels going to them. Those blood vessels are bringing in like the oxygen, the nutrients, so to speak, the food that is allowing those fibroids to grow at a faster rate than the normal uterus. So if we can block off the blood flow to the fibroids, that will essentially starve them. And a starved fibroid then begins to shrink. And as it shrinks, the symptoms improve. So we will have women that come in and see us in our clinic before treatment. Again, we've talked about how heavy their bleeding is, using pads and tampons simultaneously, changing them every 30 minutes to an hour. We do this procedure. It takes about an hour or so, maybe an hour and a half. Block off that blood flow to the uterus, and we will start seeing results within about 1 month's time, in which the woman's next period is dramatically lighter, and the heaviness, the fullness, the bloating improves. And this is all done through small particles that are used to just block off the blood vessels to the uterus and fibroids. Now, the normal uterus, it's very resilient. It'll be angry. That's what I say to patients. It'll be uncomfortable. It'll be crampy for especially the first 48 to 72 hours after the procedure. But most women are back to work within about a week's time. And the fibroids, they are incredibly susceptible to having their blood flow blocked off. And they will shrink. And we will see women a month, 2 months, 3 months out. They'll start seeing their hemoglobin or their blood counts go back up. They will not be taking extra changes of clothes with them to work. They're not spending as much on tampons and pads. They aren't missing work. Their energy levels are better because they have not been losing as much blood. They're not running to the bathroom as frequently. So there are numerous benefits to just shrinking the fibroids, leaving the uterus. And the time off is usually about 7 days, maybe 10 days for some women, but it allows them to get back into the workplace or get back to their kids, their families, other responsibilities. And we can do this all through just a tiny incision, just a couple millimeters in either the wrist or the groin artery. And it's a same day procedure. So women are going home, usually in the afternoon after their procedure's completed.
Wow, that sounds really promising. And it sounds like it's pretty successful. What is the success rate?
So success rate for uterine fibroid embolization is excellent. It's over 90% for the for well-screened patients. So Dr. Enzmann and I, she kind of alluded to it earlier. She'll see a lot of these women in the office and kind of assess the size of their fibroids, whether they're having symptoms or not, whether they might be a better surgical candidate. This is what she does every day. She kind of makes some of those assessments. And for those women that she thinks could really benefit from UFE, she sends them our way. So we are, for the right patients, again, we expect at least 90% success in treating their fibroids, seeing symptomatic improvement, and really for many of them, avoiding hysterectomy in the future. And then, as I said before, we kind of look at UFE, especially for these women in their mid 40s, late 40s, early 50s. This is just a bridge to menopause. We can get them to menopause, avoiding major operation, major downtime and recovery in a very minimally invasive, relatively low risk way with UFE.
And Brian, what is the size of, how much do they shrink? Is it still like 40% in 3 months? Do I remember this correctly?
Yeah, so 40% is what we would often see on our follow-up MRIs at about 3 months. We typically are seeing women in the clinic, we'll do the UFE, and then 3 months later, we follow them up with a repeat MRI and in a clinic visit to discuss how their symptoms have improved. That first MRI, usually it's the only MRI we need, does show usually about 40, maybe 50% shrinkage. I would say, though, in my experience, and this is just my experience, and it's not thousands of patients, but we have some patients that have gone on to get additional imaging of their pelvis for other reasons 2 and 3 years after their UFE, and their fibroids have shrunk even more than 40 and 50%. That first MRI or that 3-month MRI is really critical to make sure that the fibroid is completely dead, or all the fibroids that have, that are present that they've all completely died. And when I say die, what I want to sort of make clear for the viewers is this is a very controlled, very precise kind of treatment where the tissue death or the tissue shrinkage is what we intend, and so the chances of infection and things like that really are very minimal. So this is not like, oh, I've dying tissue in my uterus, this is a big problem over the long run. No. But what we do know is that over the course of at least 12, 18 months, if we repeated imaging, we would see even further shrinkage. We just often, because of the, I guess I would say, cost of MRI and things like that, we know for most women we don't need to repeat that imaging. But if we did, we would see even further shrinkage. But yeah, we can expect about 40% of the size of the fibroid to decrease that much. And also, I'd like to remind women, even with really large fibroids that measure, like Christina said, like a grapefruit size, if that shrinks 40%, it also softens. So it's a very hard, firm mass before treatment. Afterwards, it is incredibly soft. And so the uterus won't look exactly normal in those follow-up scans, but for the woman who's had the procedure, the things will often feel like they've gotten back to normal because of how soft and how much shrinkage has occurred. And that's a huge, again, benefit, especially for women that have the bloating, have that pressure in their lower pelvis or lower abdomen. And women will often come back to the office at 3 months and say, my pants fit better. I can eat better. And and they haven't lost any weight necessarily. It's just that the mass of the fibroid has softened and decreased.
And Brian, can I ask you, don't they sometimes actually calcify too, like get hard? Is there a way to determine when they do what, or it's just random?
Yeah, I would say that is very random. I would say the those that calcify, I have seen a handful in my career on follow-up imaging done months later. We have seen calcification occur, but often that won't start until that fibroid has really shrunk down pretty dramatically, and they're, maybe getting closer to menopause. We will see scans in postmenopausal women that do show either solid calcification or rim calcification. But again, that typically is happening after menopause, when the hormones have sort of dissipated, and the body is just, kind of lays down this calcification along the fibroid wall or within the inside. But I don't find a lot of women at that point that are complaining of even feeling their fibroids usually, because they've shrunk pretty dramatically.
Yeah. And I have one more question isn't it, they always used to say that the pedunculated fibroids, like the ones that are hanging off like a Mickey Mouse ear and just have like a thin stalk attached to the uterus, are these still the ones that are kind of hard to treat with uterine artery embolization, or that's not holding true anymore?
Yeah, the stalk, the connection between the fibroid and the uterus is really important in how we determine whether those serosal or Mickey Mouse ear type fibroids respond. If it's a very thin connection to a very big fibroid, usually we would say those are better treated surgically. Now, if there's multiple other fibroids and that just happens to be one of 10, we may still go ahead and treat. And if that one doesn't respond as well, they're, depending on where they're located, may not be causing as many symptoms as the ones that are in the inner, pushing towards the inner lining or the endometrial cavity of the uterus or in the wall of the uterus. But yes, if they have a thin stalk, so thin stalk but big fibroid, and that thin stalk's connecting the fibroid back to the uterus, those we tend not to treat with UFE. If they have a thicker stalk, those will still respond well, and we kind of document that on our follow-up MRIs.
Thank you. And can someone have UFE if they are still wanting to have children during that perimenopause time?
Yeah, so that's during perimenopause. This is, again, women that are usually over the age of 40. There's a lot of factors at play when we talk about fertility. If they're very, very serious about having children, we would usually recommend that they consult a reproductive and endocrine infertility specialist and possibly have like a surgical procedure to treat their fibroids, as opposed to having a UFE. Now, there are women that have had successful pregnancies with healthy babies delivered after UFE, but right now the general consensus would be to really seek out the specialty sort of expertise of a gynecologist who may remove one or two fibroids surgically, which might help pregnancy chances and outcomes. So avoiding UFE, if you're very, very, serious and very motivated to have children.
I think if I might just add, so in perimenopause, we're already dealing with like an ovary that's not working perfectly anymore. So the uterine artery embolization can affect or hasten a little bit the onset of menopause, Dr. Swehla, right? So in which is for the perimenopausal women with a heavy menorrhagia, they're really looking forward to that. But if you are like really around age 40 and are still, when you already have a very low ovarian function, then you don't want to add anything to it. So we would not recommend that. And in younger women, that's an entire different conversation with the uterine artery embolization. I'm not sure if we're going to get there today.
Sure. Yeah. So thank you for that, Dr. Enzmann. What if UFE doesn't work? What are the options there? And it sounds like there's a lot of partnership between the two of you, and as well as the individualized aspect, because it sounds like there's factors in that. Your treatment plan is going to depend on the size of your fibroids, all the other factors that you talked about. So can you talk about what are the options if UFE doesn't work, and how you work with your team to put together that plan and talk through those options with your patients?
Yes. So, if the uterine artery embolization really failed, which is not very common, as Dr. Swehla pointed out,
Right.
then we're usually talking about really big fibroids. They're not shrinking, or they're growing, which we really don't like because we're always concerned what is going on. So at that point, I do recommend a hysterectomy usually. Then, and these are going to be patients who we had tried all other conservative options before, like probably she has tried the progestin options, the birth control and the progestin IUD, and all of this failed. So after the uterine artery embolization, I wouldn't recommend going back there. Then we're usually like, it's really uterus of fibroids that don't respond well, let's go for hysterectomy. Because at that point, these women have been going through so much, they want a resolution of their symptoms. And then I would recommend hysterectomy, yes. And then it depends if we can do that laparoscopically. It depends on the size of the uterus and how many babies that woman has born vaginally, if I can do it laparoscopically. And sometimes if it's really a very big, I call it a bulky uterus, that's causing all this pressure and pain, sometimes we still have to do old-fashioned hysterectomies with a bikini cut. Yes.
Mm-hmm. Okay, thank you. Appreciate that. So, Dr. Swehla, how does someone get a referral to see if they qualify for UFA?
Yeah, so oftentimes patients will, within MedStar in the Baltimore area, we'll have our gynecologists, their gynecologist, the patient's gynecologist, make the referral to our office. We also have women that self-refer. They know they have fibroids. They're having lots of symptoms, and they can reach us. There's a couple ways through the MedStar website. Searching my name. Our office number is 443-444-4343, lots of fours and threes. But that they can, see me and kind of come in self-referred. I had a patient this morning here in the Bel Air office that was self-referred. So we will see patients at Good Samaritan. I also have a partner that sees patients at Franklin Square, and then we see patients in the Bel Air office. And we perform the UFE procedure in the Baltimore area at Franklin Square and at Good Samaritan. Good Samaritan is sort of my home base. Dr. Enzmann is there for now. And we have clinics where we kind of go through all the specifics, really from reviewing the symptoms, the imaging, and then really setting expectations for what the day of the procedure will look like, because I think that's very important. So there's not any kind of confusion as to how the day is going to go, setting expectations about how long the procedure usually goes, and then really what the recovery is going to look like. And patients appreciate that. And then the follow-up. So I will always follow up with the patients, and really after usually that 3-month appointment, if everything's going well, the MRI looks great, their symptoms are doing well, we encourage women to return back to their gynecologist for their annual well women exams. And so that's it is a partnership. Dr. Enzmann's expertise and just kind of the total care of the patient, of the woman, and then my specialty sort of expertise when it comes to the UFE and managing everything that goes into that.
Thank you so much. That's really helpful. This was a lot of great information. I did not know anything about uterine fibroids going into today's discussion. Now I feel like not quite the expert that you are, but I feel like I have enough to at least help educate my friends and family. So it sounds like there are options out there. And if you're having symptoms, or even if you're not having symptoms, you should continue to have your regular appointments, have conversations with your gynecologist and you all about different things that are happening in your body. So thank you so much for providing us with this information. And I'll remind our watchers to please share this with your friends and family. This is good information for us to have. So before we wrap up, Dr. Swehla, anything you want to make sure that our viewers take away from today's discussion, or anything you want to make sure that you share with our viewers before we wrap up today's broadcast?
I think just to summarize, fibroids are very common. And we know, though, they can be very, very disruptive. sort of life-altering. I have met so many women who have been struggling for years through their 30s into their 40s with just terrible, really, for lack of a better word, horrible periods. And there are options, especially if fibroids are the cause. And whether it be with UFE, which is a fantastic option, or some of the options that Dr. Enzmann has, that she offers, we would love to be able to help. And there is relief that is there. And I can't tell you, I mean, I think for me, it is probably the most favorite sort of procedure that I perform, because those 3-month visits after the UFE are just so wonderful. Women are just overjoyed they feel like they've gotten their life back. And they don't have to worry about accidents. They don't have to worry about taking extra changes of clothes with them wherever they go. They feel so much more energy, and they're not dealing with those debilitating cramps and the bleeding. And so just the relief that they experience, for me, is worth all the time and energy that we put into providing this procedure. The partnerships with Dr. Enzmann and other gynecologists across MedStar, it's just exciting to see what can be achieved. So I appreciate this opportunity to kind of share a little bit about what UFE is and how it can help.
Yes, thank you so much. I think about that procedure too, when you were talking about there's options there. The success rate was really impressive to me. So if this could be a good option, it's a great option that we have available to our patients. So thank you for that. And thank you for everything that you do. Dr. Enzmann, any final thoughts from you?
Yes, I wanted to tell our viewers. So I think the uterine artery embolization is really a procedure that every woman with fibroids should be offered. So it needs to be reviewed if she's a candidate. So if you have a gynecologist who never mentioned that to you and who wants to get you straight to a hysterectomy, then please self-refer. Get to a specialist like Dr. Swehla and let him have a look at your imaging and give you his opinion, because really everyone should explore that option. That's what I think.
Thank you so much. Appreciate it. Well, thanks again. That concludes today's discussion. I want to thank our viewers for tuning in, and of course to both of you for taking the time out of your day to share your expertise with our viewers. We have a ton of resources that we're going to share with you all. It'll be in the comments, links to our websites and phone numbers. So there's lots of resources out there. Thanks again for taking the time out of your day to watch, and have a wonderful rest of the day. We'll see you next time.
Bye-bye.
Bye.
Bye.